Okay. Good morning. Where is everyone?
Good evening. I don't know.
No.
9:30.
Oh, it is. I know Brianna's not gonna be here, but
So it's just Ariana then.
that girl's never actually been.
Good morning. I'm like 10 minutes away, then I'll switch devices so that I can turn my camera on, okay?
Yeah, you're good.
Thank you.
Folks, just a minute.
Can you please drill all these rhythms and
Do it today.
burr holes and then just pack them in there?
Okay, everybody can hear me good?
Yes.
Yes, I can.
All right, let me know if it starts getting weird. And then I'll switch over to my laptop. I feel like it always gets weird like an hour in. And then we have to switch. How was clinical?
It was just good.
How was clinical for you guys?
It was good.
I was. How was clinical?
It was good.
Like my friend Shauna.
Yes, we do.
Yeah, she's great.
Good. Okay. Last week was a very long week. I worked 70 hours. No. Thank you. Oh, and you're. Remember, they're coming tomorrow, and they're gonna be here on Wednesday. We are going to be on the best behavior, and we will not have drinks, and we will not have food, and we will not have anything. And then they're gonna leave, and Jessica's gonna be able to. So right now, I really feel like I can't breathe. Your girls. Go. Okay, so how are we all feeling about our rhythms? Okay. Everybody got my email not to stop at part blocks. Yeah. So I obviously did not expect you to upload anything because it wasn't done beat, right?
I did it anyway.
I already started recording. So
I look for that now.
yay. Yeah, thank you.
I'm too used to like teachers.
Yeah, like it's late. So let's get through the rest of the PowerPoint. We're gonna go over. And then we are going to go over our scripts and we are going to practice them until cows come home, I guess. Okay.
That's what I'm saying. But okay, to be honest, even
I like this. Okay. That I forgot for judge. Bad enough. Okay. Ooh, I forgot. Remind me, I forgot that attendance number.
close. Family. Oh, maybe. Oh, anyway.
So this is a very, very busy picture. Okay, so we have a first degree block. Which is abnormally slow conduction through the AV node. So your SA node is firing just fine. And your AV node is slow. So the causes, this could be normal for some people. It could happen with age. It can happen with cardiovascular disease, coronary artery disease, electrolyte imbalances, and medications that slow AV conduction, like beta blockers and calcium channel blockers. These patients are usually asymptomatic, and they don't really usually require treatment. And really, you just want to make sure that these patients don't go into a complete heart block. So the rate is normal, but it can be slower because of the slowed AV conduction. The rhythm is regular. The P wave is normal. It's before every QRS. The PR interval is prolonged. And there's a little tricky thing up there that says if the R is far from P, then you have a first degree. If the R is far from P, then you have a first degree. So if your PR interval is longer than 0.20, you have a first degree block. How do you feel about first degree blocks? I feel like that's kind of it's probably the easiest block, just because it only has one characteristic, right? Everything else is normal except for the PR interval. Granted, the rate could be a little slow, but theoretically, everything else is normal except for that lone PR. Okay? So that's why it's important for us to know what a normal PR is, which is what?
0.20.
What was the first number?
0.12.
Okay, so a normal PR interval is 0.12 to 0.20. So then we have our second degree type 1. There are two types of second degree blocks. Your type 1 is also called a Winkie-Bach. I always like that word, Winkie-Bach. So the PR interval is progressively lengthening until the QRS complex is dropped on the fourth beat. So it's longer, 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 and then drops. So you have this, let me have this. So you have your first PR interval, and then your next beat, it gets longer. Your next beat, it gets even longer. And then the next beat, there's just no QRS. You have your T wave, your P wave, and then nothing. And then another P wave. Okay? And then it usually goes right back into the cycle, into a sinus rhythm. Or the cycle restarts and your Winkie-Bach just continues. Okay? So if your PR interval starts normal, and then the next one gets a little bit longer, and then the next one gets a little bit longer, and the next one, boom, there's no QRS. We have a second degree block in the first degree. There's a couple causes. Rheumatic fever can be one of them. This isn't something that that you usually see in younger people. You usually see rheumatic fever in older adults that had it when they were young children. And rheumatic fever can cause a lot of issues as they were like growing up, especially cardiac conditions. Another cause can be an MI, increased vagal tone, medications like beta blockers and calcium channel blockers. Your symptoms, the patient may be asymptomatic, but they can also experience dizziness, shortness of breath, weakness, altered mental status, and chest pain. What are these symptoms from, do we think? Every fourth beat, you have a missed ventricular contraction. So what's decreased?
Blood flow?
Cardiac output.
Cardiac output, right? So if we have a missed fourth every fourth beat, you have a missed ventricular contraction, then that means that blood that's in that ventricle isn't going out. So we're missing an opportunity for oxygenation. So that's going to affect our CNS, that's going to affect respiratory, it's going to affect our energy, could even result in syncope if the patient was really symptomatic and you have dizziness and weakness, altered mental status. Of course, that's going to put us at a fall risk, right? So safety is an issue.
Acidity, ventricle.
That's a good point. So Monica said that there could be an increased risk of clotting because the blood is just sitting in the ventricle. I think that if this was something that was persistent, then that could absolutely happen just from blood stasis. If this is something that's like kind of coming and going, maybe not, just because it's every fourth beat. So that next QRS complex is going to push that blood out.
Okay.
But absolutely a possibility for sure. The treatment, if symptomatic, first of all, you always want to notify your physician, not just if they're symptomatic. If this is a new onset of any arrhythmia, listen to my words, new onset of any arrhythmia, you would want to call a provider. If you notice that your patient has all of a sudden gone into a second degree block, and you look in their chart and they have absolutely no cardiac history of a second degree type 1 Wenckebach, you are calling a provider and saying, hey, just want to let you know that your patient just went into a second degree block for the first time. And guess who's getting a cardiology consult? Our friend that just went into a heart block. Okay. And then for other treatment, we want to check vital signs. We want to check our patient's oxygen status. EKG, we want to confirm. So EKGs are really, really good at confirming what we're seeing. Okay. So you see a patient, you're like, oh, I think this might be it. I think this might be it. You print a strip, get an EKG, because that EKG is going to interpret your rhythm. It's going to literally tell you at the top the length of your PR interval, the length of your QRS. What is the interpretation of that rhythm? Okay. And then possibly some labs. So your rate is normal, your rhythm is regular, your P wave is normal, your PR interval is progressively getting longer. And it drops, the QRS drops every fourth beat. Any questions about a second degree block type 1, also AKA Wenckebach? No? Okay, so then we have a second degree type 2. Bits. So the P waves stay constant, they don't progressively lengthen, and a QRS is randomly dropped. Okay. So these are similar when it comes to the QRS. The difference is that the PR is not, prolonged, like getting longer and then longer and then longer. The PR is the same throughout. So, what does it say? If some P's don't get through, then you have a Lovitz too. Your causes are coronary artery disease, cardiomyopathy, and MI, medications. I mean, pretty much it says the same thing when it mentions medication, beta blockers and calcium channel blockers. So at this point, we have to know that these two drug classifications put us at a higher risk for going into a heart block, right? Your symptoms could include dizziness, weakness, and syncope. Your patient could be asymptomatic. You want to consult cardiology, review medications, possible temporary pacing, subcutaneous or transcutaneous pacing. And may lead to a permanent pacemaker. She's smiling with her crazy eyes. So this, a Movitz 2, is more likely to progress to a third-degree heart block. So if you notice, we're getting to we're progressing, right? The first degree, it was like, we're not that bad. We're just gonna watch and make sure and monitor. And then the second degree, type 1, Winky Bach was like, they could be symptomatic. We want to get a provider, get some meds. Now we're on to a second degree type 2, which is now getting into pacemaker territory, excuse me. We're getting to a place where we got to do something about it. So now we have our third degree heart block. This is a complete loss of communication between the atria and the ventricles. Okay? They are not talking to each other at all. So in a normal cardiac conduction, the P waves tell the QRS to do what it needs to do, right? The SA node tells the AV node, tells the bundle of His, tells the Purkinje, which make the atria contract, relax, the ventricles contract, relax. And there has to be constant communication between this electrical activity. In a third degree heart block, there's no talking. Okay? So if your P's and Q's don't agree, then you have a third degree. They are random P waves, random QRSs. You have P waves, and then no P wave before your QRS. You have 2 P waves, and then no QRS in between. It's just a free-for-all. It's an absolute free-for-all. And usually, this rhythm is very slow. Usually, your patient is sitting with a rate of like 30s or 40s when they're in a complete heart block. Okay? The P wave is completely independent from the QRS. The PR interval is variable. It's whenever a P and a Q come together, that's when you're going to have a PR interval. But if you have 2 P waves, 3 P waves right after each other, there is no PR interval. So it's constantly changing. And your QRS is independent from P waves. This is a medical emergency. The heart cannot sustain this rhythm. The patient has to be put on pacing. They have to go either get a permanent pacemaker right then and there, or they're going to have transcutaneous pacing until they can get to the cath lab and get a pacemaker placed. So causes can include an MI, cardiomyopathy, ditch toxicity, and coronary artery disease. Your symptoms are resulting from decreased cardiac output, so hypotension, chest pain, weakness, your patient's pale, clammy. We have a weak pulse, okay, because there's no P's and Q's talking to each other. The treatment, if you see your patient is in a 3rd-degree block, you're calling a rapid. Somebody needs to get to the bedside. A provider needs to get to the bedside immediately. We can use atropine to try to increase the heart rate and increase cardiac output. But that's really just a temporary treatment. You need to fix the cardiac conduction system. You can put them on the defibrillator and do transcutaneous pacing through the defibrillator. We call this synchronized pacing. Okay. And then they have to get a permanent pacing. Any questions about the 3rd degree? Okay. Asystole. Asystole is when the heart stops beating completely. There is no electrical conduction. None. There is no rate, there is no rhythm, there's no P waves, there's no PR, there's no QRS. There is nothing. Right? This is caused by an MI, an electrical shock, hypothermia, untreated VTAC, right? We were talking about VTAC. If VTAC is not treated promptly, the heart will stop. Electrolyte imbalance, drug toxicity / overdose. Symptoms include loss of consciousness, obviously, they're dead. Agonal breathing or apnea. When a patient cardiac arrests, little breaths, which is what we call agonal breathing. It does not mean that they're alive. It just means that the brain is still telling the lungs to breathe. Okay? And it's not going to last long if you don't get that heart restarting. And of course, we are not going to have a pulse. There is no pulse with asystole because there is no electrical activity. We are immediately going to do what? Start CPR.
CPR.
Immediately, we are going to start CPR. And as soon as that code card gets in the room, and as soon as somebody hands you epi, somebody is pushing epi as fast as possible. Okay? But during that time frame, you do not stop CPR. Okay? And follow ACLS protocol. We are going to go over that next. So remember I told you that there was a difference between cardioversion and defibrillation. Okay? So,
Yeah.
by the way, this should be on 2 separate slides. Okay? Because asystole is not a shockable rhythm. I want you to make that very clear in your brain right now. Asystole is not a shockable rhythm. Ever, 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 ever. Okay? So, right here at this point, going down, we are talking about 2 completely different things. Understood? Okay. Cardioversion is planned and synced shock waves that are delivered on your R waves. Okay? So when I say synced, what I mean is that defibrillator literally is tracking the R waves. Okay? And it's a specific button that you have to press on the defibrillator that says sync. And it tracks every R wave. So every QRS, every time you have a QRS and the tip of that R is going to tick, tick, tick. Okay? It's used for SVT, AFib, and stable VTAC with a pulse. And remember, I told you the joules, the electrical activity that we're using is much lower.
They said they got to see cardioversion done.
Oh, nice. So the joules used are much lower. With a healthy, well, not healthy, that's a lie. With a regular sized adult human, you're going to start at 50. If and when you start talking about kids, or if you ever work at a pediatric hospital, you will learn that it is much, much, much less for a small child. Okay. And we need consent from this patient. This patient is still alive in front of us. Okay. Not really a signed consent, but they need to know what's happening to them, and they need to understand that that they are about to be cardioverted and shocked. And they need to be ready for it. Okay. Because it hurts. Shocking is very painful. Have you ever gotten shocked by a plug? Right? And your finger, like, it hurts. So now you have pads on a patient's chest and it's zapping their body. So it is painful. If you have time and it's not like an emergent cardioversion situation, if you have time, most of the time you give pain medicine like morphine before you deliver cardioverted shocks, if you have time. And then you have defibrillation. This is unsynchronized. Why is it unsynchronized? What are we shocking?
Unsynchronized, right? There's no.
What rhythm are we shocking?
Pulseless.
Good job. So we are shocking VFib, and we are also shocking pulseless VTAC. Okay. There is nothing for it to sync to. You don't want your defibrillator syncing to pulseless VTAC with a rate of 200. Okay. So your joules are going to start at 200 always, unless it's a small child. Start at 200 and max at 360. Do we have any questions about asystole? One thing I want to go over, because there is especially on the homework, there is a strip that is wrong and I don't agree with. Asystole is a flat line. Flat. Okay. If there is any variation in that rhythm or in that line, going up or down, that is called fine ventricular fibrillation. Okay. There is a difference between fine VFib and asystole. Asystole is a flat, pulseless, no electrical activity whatsoever. Right? So if you were to see a rhythm that had some wave fibrillation to it, but it's small, it's still VFib. Okay? Any questions about asystole, cardioversion, or defibrillation? We're going to go more into shocking when we do asystoles. So you have waviness. You have a random ventricular beat. You have a little flat. Okay. So if I were to see this on my patient, that's VFib over there. This is a random cardiac conduction that's just happening. And then that's good. Okay, we are continuing CPR. This isn't really a good strip for interpretation because this is, I want you to recognize when you look at this that this is not a good QRS, right? It's completely wide. It's not doing anything, and there's only one beat. So this is not spontaneous conduction restarting. This is I'm doing CPR for the next 2 minutes until we have a pulse check. What is this? No, friends.
Asystole.
Asystole. Okay. So you can get out your little cheat sheet. Remember that page in your PowerPoint? That I'm pretty sure it said at the top, cheat sheets. Like mid PowerPoint, I think right before we started practicing. And what page is it? Or what slide? Huh? 19 and 20. 19 and 20. Slide 19 and 20. All right, so what is our rate here? It's
70.
I only count 60.
60.
60. Okay.
And
We
60.
have a regular rhythm. Yes.
It's regular.
Looks regular to me. Okay. Do we have a P wave and does it accompany a QRS? See, now that we've talked about a 3rd degree heart block, now you realize why I'm asking you if it accompanies a QRS. Do we have a P wave and does it accompany a QRS? Yes.
Yeah.
Yes.
Yeah.
Okay. So what is our PR error?
I got
It
24.
was measurable, right?
What'd you say?
I got 24.
Is it 24? 0.24?
Anybody else? Anybody else get that? I counted 6 boxes.
That's what we counted, yeah.
So we have a what's happening here? Is that normal?
It would be
No,
a 1st degree.
We have a prolonged PR interval. 6 times 4 is 24. Our normal PR interval is 0.12 to 0.20. And if our PR interval is 0.24, that means it's prolonged. And we have a 1st degree block.
Slots.
Yeah, how did your health say?
Can you show me a PR interval again for the ninth time?
Oh, okay, never mind.
Because
Your interval is where
is it the end start? Is it the start of our or the start?
No,
of the-
it is always the start.
For our-
It is the beginning of the P to the start of the R. So we have 1, 2, 3, 4, 5. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. So it is the start of the R, or I'm sorry, the start of the T.
I can't see the loop.
Does everybody see that? So what is our QRS?
I know, I can't.
What is the length of my QRS?
About 20, I think.
That's what I don't want to be wrong, but I got 20.
Those boxes are so light to see.
You counted 5 boxes between the QRSs?
Yeah.
About 4 or 5.
I see. Is it three boxes between the QRS? Like 3.5, maybe.
Yeah, I would agree with like 3.5, 4. Most of them are a little bit longer than 3. Some of them are about 4. So what is our normal QRS?
0.06 to 0.12.
Okay. So if this is like a 3.5, our QRS is a little wide. Okay. Okay, so we all agree that this is a first degree block, yes? And how we are recognizing that? Along our interval. Okay. So what is my rate?
60.
60.
Is my rhythm regular?
Yes.
Yes.
Do I have a P wave and does it accompany a QRS?
Yes.
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 What is my PR interval?
Oh, God. Eight.
Sir.
So much easier.
I agree. I agree. So what is that? Sorry, my brain didn't realize what you were saying. I think if my brain just went like. All right, so how many boxes do we count?
I got 9.
I got 8. I think one of them I saw 9, but the majority I saw 8. So what is our PR interval? What is 8 times 4?
0.32.
32.
And what is our QRS?
It looks like a 8.
Yeah, I would agree. It's like a box and a half. Yeah, I would say
Yeah, so
0.
0.6.
Yeah. So what is this?
First degree.
First
This is the
degree.
first. And what is the characteristic of a first degree block?
Prolonged.
Prolonged PR.
PR.
Okay.
Second degree.
Yeah,
What kind rate?
second degree.
This second degree.
That's a winky box.
Type 1. I can look at this and see.
It's rate 60. And is it regular? No.
Mm-mm.
Do I have a P wave? Does it
Yes.
accompany QRS? No.
No.
Okay. So 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4. P. So I got longer, and then I got longer, and then I got longer, and then boom, dropped. And that is a
Monkey bump. Winky bump.
second degree type 1 winky bomb. Can we call winky bomb some of the best? You have to know the difference between a second degree type 1 and a second degree type 2. You must recognize both terms. Can we call them their fun names? You must recognize both terms. Does everybody understand how we got to this conclusion?
Yeah.
It's okay. Speak now, please.
This one, yes. The rest of them.
This one, yes. She's like, this one, yes, I get this
I
one.
know the longer drop. I got that.
Okay. So, what is my rate? 60.
60.
Good. So I have 1, 2, 3, 4, 5, 6, 7, 7.5. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Oh, drop. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Bet you there's a drop beat after that last one.
Type 1 again.
So this is a what? Online friends.
Second degree type 1.
Second degree type 1. Winky box.
Longer. If they same gradual and then still.
Moment 2 has the same constant PR. And PR does not get longer, longer, longer. Okay. So what is my rate?
70.
My rate is 70. I'm starting off strong with a drop beat. I already got a drop QRS here. Now, this one doesn't have my little teeny tiny boxes. I kind of like it better. But if we had calipers, we could tell that this, and this, and this, and this, and this, all of these PRs are the same.
The same. Second degree type 2.
Type 2. AKA Mobitz 2. You remember 2 and 2 go together. So type 2, second degree, Mobitz 2. They all have a 2. So we can all understand or see that the PR interval in this strip is the same with every single beat. What is my rate?
Down the last one.
40.
35.
Yeah.
35. Okay. So my rate's 40. What is my PR interval?
Four.
I want you to say, Jess, it's really hard to see that, but I can tell you that they're all the same because I measured them against each other. So if my PR interval is exactly the same, and I have a dropped QRS, what do I have?
Two Mobitz.
Degree type 2.
Mobitz 2. His name is government name.
That's right.
Can you repeat that? I'm sorry.
That last strip was a second degree Mobitz 2. Second degree type 2. This rhythm makes me panic. I want you to understand that when you see this rhythm, you panic. We all panic.
I was panicking before I saw
Everyone's
Must be
panicking
third degree.
this rhythm. Because what do we have?
very.
Okay, what else do we have? Who's not talking to who?
P's not talking in
You are.
P's and Q's
QRS.
are all jacked up. I got P's and T's. This is the P, or this is the T going into a P. I got P and a P and a T and a P and a P and a P and Q everywhere. Nobody's talking to anybody. What do we need? What's the
Third
position
degree.
need?
All about it right now. That's what you need.
Atropine.
Transcutaneous pace pacing or
Transcutaneous pacing.
none of these or pacemaker.
And a pacemaker. You gonna get a pacemaker.
What?
You are absolutely going to get a pacemaker.
I don't know.
Transcutaneous pacing is temporary. They can't walk around with a defibrillator all day, every day. Just like, oh, yeah, this is my little friend. Got a little cart next to you and just rolling it around, portable battery and everything. No. Transcutaneous, subcutaneous, percutaneous, all different terms for pacing, are temporary until you get a permanent pacemaker.
Not real good.
You forgot her. What is this?
Yes.
Say it.
3rd degree.
It's a 3rd-degree heart block. Who's not?
He's not toxic you.
P's not talking to Q. P is giving the Q the cold shoulder. She said, I didn't want you here.
He is mad at Q.
P is mad at Q. Guess what?
That might be a few.
Q was gone for 3 days and he came home and he said, P, please forgive me. And P said, oh, okay.
I just wrote he is mad at Q on his
Mad
side.
at Q.
Hoping. But I doubt. Why?
Complexes.
The 3rd degree block we just did does not have wide Tourist complexes. It doesn't have much of Tourist complexes. Wide ones just can't.
No.
It says for
The only distinguishable trait of a 3rd-degree heart block is that the P's and Q's are in no communication to each other. Not talking. Be mad.
I feel like I'm just running. Like I would, if I can learn this, I would. Right, don't call me, I don't know what. He's probably meant.
Okay. Let's talk about ACLS. Actually, let's take a break. Let's take 10 minutes. And then we're going to come back and talk about ACLS. 10 minutes. Thanks. Call 911 anything. Everything might be. Everybody back.
Yes.
Yes.
Can you guys see my screen?
Yeah.
So BLS, okay? Yeah. So we see someone down. What is the first thing you do?
See.
You check for safety. We do not put ourselves at risk. Okay. Remember the Grey's Anatomy episode where everybody's getting electrocuted in the basement because nobody's checking for scene safety? They're just stepping in the water and then getting electrocuted. Okay. If only they have some rubber boots. All right. So first things first, scene safety. Hey, are you cool? You good? You breathing? No? Okay. Check for a pulse, carotid or radial for 10 seconds minimum. Check for breathing. Okay. I'm saying this just because I heard you guys talking about it earlier. In a cardiac arrest situation, especially with ACLS, we are not checking a radial pulse. Okay. You are checking a carotid pulse. You are checking a femoral pulse. You could listen for a apical pulse, but you are not checking a radial pulse when you are doing ACLS. Okay. Because if you do have a very sounding, a very weak heart feeling, it's like, hey, you're cardiac arresting. Let me see if you have a pedal pulse. Okay. The farther you get away from the heart, the harder it is to feel. So if you are in an emergent situation and you need to check for a pulse quickly, 10 seconds. 10 seconds goes by really fast. Go for a major large artery. Okay. So carotid, femoral. Right? And if it's a baby, brachial. Don't want to put your fingers on their little tiny necks. All right. So your patient has no pulse. Your patient is not breathing. So then if you are by yourself, you are going to do compressions 30 to 2. If you have another person, I know it says 3 people. Most of the time you really don't have 3 people. But if you are by yourself, you're going to do 30 compressions, stop, give 2 breaths, back to 30 compressions, give 2 breaths, back to compressions, give 2 breaths. You're going to do this for a minimum of 2 minutes before you do a pulse check. Okay. And during that time, hopefully there's someone that can go run and get an AED. Okay. And we're talking if we're like out in the world, in the community, you're at the mall and someone has collapsed. You go to them, hey, are you okay? You check for a carotid pulse, it's not there. The patient's not, or the person is not breathing. You look up and you say, you're one. That person is on the phone with 911. During that CPR, stop CPR for 2 whole minutes, other than to give those 2 breaths. Okay. 1 full cycle of CPR is 2 minutes. Full where
Jessica, you're going in and out.
above the I'm going. Okay. Can everybody hear me?
Yes.
Yes.
All right. Okay, so when we say full depth and recoil, what does that mean and why?
Push all, well, press all the way down and then let the chest rise back up all the way.
Okay, but what is the point of letting the chest rise back up all the way? So it can refill. Okay. So when you're pressing down, you are contracting, bless you, and pushing all the blood out of the heart. If you don't come all the way back up, the heart cannot refill with blood. Okay. So that's why we have to have full depth and full recoil. All right. Minimum interruptions between compressions and breaths. And then once we get a defibrillator or an AED, first of all, the AED, we all did the simulations. It is going to detect a shockable rhythm. If it has one, it is going to tell you that it detects a shockable rhythm. It is going to lead you step by step through BLS and also delivering a shock. Okay. Now we are moving on to ACLS. Okay. So your patient has cardiac arrested. You run into the room, you start CPR. You hit the code button. Somebody hits the code button. The code people come. Okay. The code cart comes. The code cart gets there, you attach the pads. Right? Without the pads, we can't look at the rhythm. Okay. During that first 2 minutes, what are we not doing?
CPR.
Stopping CPR. You do, it's not common sense for a lot of people. Okay. During that first 2 minutes, you are not stopping CPR. Right? Because there is enough oxygen in the blood that is in the body right at that moment to oxygenate the brain and your vital organs in those first 2 minutes. We have learned through evidence-based practice that a person has a better survival rate and less brain damage if you do CPR uninterrupted for the first 2 minutes. Okay? So we have now gotten to a place where our pads are on the chest. We are stopping for a pulse check. At this point, you have an entire code team and a physician and someone documenting time to say, it's time for a pulse check. CPR stops. There is usually multiple people. One person is checking for a carotid pulse, another person's checking for a femoral pulse. And this is only lasting 10 seconds. We cannot waste time. Okay? If at that point we say there is no pulse, you look at the monitor and you see that your patient is in VFib. Or you see that your patient is in pulseless VTAP. Pulseless. That's supposed to say pulseless. Pulseless VTAP. What do? How long does it take to charge up a monitor?
Shot.
Keep doing CPR until it's charged, I assume, but I have no idea.
It'll say stand by analyzing rhythm and it'll say shock.
Oh, you did like,
eyes.
it's like an 80, not the full.
We're in the hospital. We are in the hospital. Our pads are on our patient. We have determined that our patient has a shockable rhythm. The next thing you do, you restart CPR. The person that is manning the defibrillator hits charge. First of all, sets the joules, hits charge. As soon as that defibrillator is ready and charged, that person on the defibrillator says, everyone clear. And in that moment, every single person around that bed is off the bed, off the patient, and they all say, all clear. And then you hit shock. The shock is delivered. The person that is doing CPR jumps right back on the chest. Okay? We do not stop CPR while the monitor is charging. That is wasted, precious time.
I did that. I accidentally hit stand clear before the AED said everybody clear, but right after I hit it, it was like, everybody clear the patient. I was like,
That's okay.
thank the Lord.
So, our patient's in VFib or pulseless VTAC. We deliver a shock. 2 minutes of CPR immediately. Okay? Hopefully your code team has arrived and your patient or you have a respiratory therapist or somebody that's providing breaths for this patient. Okay? Most likely an ambu bag. And possibly while you're checking for a pulse, someone is intubating this patient. Okay? So after that second round of 2 minutes of CPR, you are then going to analyze for a rhythm. I'm asystole. What do I do? I'm immediately going back to CPR. Well, first of all, pulse check. No pulse, asystole. Back to CPR. We haven't even talked about drugs yet. Okay. At this point, we've only talked about CPR and shockable rhythms. What is PEA? Pulseless electrical activity. What does that mean?
So there's some electrical activity in there. You can see it on their rhythm, but there's no pulse.
Okay. So you see some type of rhythm, but there is no palpable pulse. Okay. So this can even look like a bradycardic rhythm, but there is no palpable pulse. PEA and asystole are the same when it comes to shocking. You cannot shock pulseless electrical activity. Okay. So you start CPR back up again, 2 minutes. What do we want to make sure we do every 2 minutes of CPR? I'm tired.
Switch.
Switch CPR providers. If you're in the hospital, believe me, there are going to be plenty of people for you to switch with. Okay? The first medication that you're going to give in ACLS is epi. How fast do we push epi? Is your patient dead? Your patient's dead.
So you don't push it fast.
You gonna give it. Your patient's dead. They're not gonna get deader. We want them more alive. Their heart stopped already. Okay. So epi can be given how often? Every 3 to 5
Every 5 minutes.
Every 3 to 5 minutes. So, in a regular old code situation, you have your recorder that's taking time they are going to tell you every time you hit that 3-minute mark that it's time for epi. Okay. Yes, it's 3 to 5. Research says that 3 minutes is the best outcome for your patient. There are a couple other drugs that we can give during a code. We can give amiodarone IV. Our first dose is going to be 300 milligrams, and our second dose is going to be 150. Most of the time, you're going to give at least 2 rounds of epi before you even open amiodarone. Okay. We will continue CPR until we achieve ROSC, which is return of spontaneous circulation, or the doctor says enough is enough, or the POA says stop. This could be 10 minutes. This could be 30 minutes. This could be 2 hours. If you have a 5-year-old that had cardiac arrested, do you think you're going to stop after 5 minutes or 10 minutes? You have a drug overdose of a 17-year-old. Do you think you're going to stop after 20 minutes? You have a 95-year-old grandpa and you just broke every single rib in his chest. You think we're going to call it after like 20 minutes, maybe 30? No, it's up to the provider. At that point, it is up to the providers. Because during that moment, there is a resident out in the hallway with Mima or daughter or son talking about what they're doing, how they're doing it, the success rates, and what the possibilities of survival are in that moment. So while this is occurring with 95-year-old Papa, somebody is talking to them about end of life. Okay, so once we have ROSC, you stop for a pulse check. And somebody says, I feel a pulse. And you look at the monitor and you have a rate of 68, sinus rhythm. What's next? Hopefully they're already intubated. She said, give them some oxygen. I'm hoping they have already received an airway while you've been doing CPR. That's a good question. Your patient has achieved ROSC. What are we doing? Are we just gonna stand there? We looking at him? Yay, everyone! We did it!
Vitals, right?
We're going to transfer to an ICU. We are immediately getting that. By the way, your code team is most likely an entire team of ICU nurses and their residents and their intensivist. Okay, that's your code team. So your code team that includes your ICU nurses and your nurse manager, she's out in the hallway and she already called the ICU and she's like, hey, I got a patient, we're coming down, we got him back. And they say, okay, go to bed 23. So you have your ICU nurse that's stuffing her pockets with epi, and then somebody's running and going getting the elevator, and then you are flying down that hallway, getting in the elevator and getting that patient to the ICU as fast as possible. Because guess what? Bro, code wants to code again. Okay? Because most likely we need some pressors. We need more drugs. We need more monitors. We can't do this on a med surg floor. We can't do this on a tele floor. We need to get this patient moved and stable as fast as possible. Why is my nurse stuffing epi into her? Because the patient's got code in the elevator. Guess who has ridden down on top of the patient, on top of a bed, doing CPR down the hallway to a patient's ICU room? Okay. If your patient codes in the elevator, you're jumping on the bed and you're starting CPR while that bed is moving. Okay. So we want to make sure we are monitoring our patient. They are being transferred to a higher level of care. You are never going to keep a code patient on a tele floor. Oh, my patient coded an hour ago. We kept them. No, they need to go get monitored. All right. Oxygenation, like I said, our patient is intubated at this point. Somebody has a bag and they're bagging this patient. As soon as we get to the ICU, there's a vent waiting for that patient and they're going to be immediately hooked up to their vent. Okay. At that time, most of your patients that code are not jumping off the bed after you achieve ROSC. Okay. Most of the time they are in, I don't want to say comatose because I don't want you to think that's like they're in a coma because that's not really it. It's not, they just don't come back to life and then just spring up and start fighting you. Don't get me wrong, it could happen, but that's not really the norm. So we need sedation. I know, that's why I'm telling you. So we need propofol, we need fentanyl, we need, now this analgesics fentanyl drip, fentanyl is also in ICU, also used for sedation. Okay, we use fentanyl for sedation in the ICU. We also use Versed for sedation in the ICU. So you could have propofol, fentanyl, Versed, and then if your patient's real froggy, a ketamine drip. But that's only if they get really frisky and the other stuff isn't working. Okay. Most likely you're going to need fluid resuscitation unless the person is hypervolemic and they actually coded because they went into flash pulmonary edema. You probably don't want to give more fluids. And then you want to do continuous vital sign monitoring. This patient is going to be on a continuous tele monitor, probably get an art line. Okay. Okay, so your patient is in asystole. Are we shocking?
No.
No. Your
No.
patient is PEA. Are we shocking? Your
No.
patient is in pulseless VTAC. Are we shocking?
Yes.
Yes. Our patient has VTAC but has a pulse. Are we shocking? No. What are we doing?
No.
We're doing dang.
No. What is the first thing that we can do? That you can tell the patient to do?
Bear down.
Vasovagal. Bear down.
Yeah, the vagal. Bear down.
This can be used for SVT and it can be used for VTAC with a pulse. What if your patient has sustained VTAC? What do you have to do?
The adenosine.
Adenosine, right?
Nope. Cardioversion. Synchronized cardioversion. We're not defibrillating at 200 joules. Atropine? What does atropine do?
Increase the heart rate.
Atropine and adenosine are two very different drugs.
Atropine
Atropine
increase the heart rate.
increase your heart rate.
And adenosine stops.
No, we already have a rate of like 200. Adenosine is the 6 milligrams and then the 12 milligrams. I know, but it's important that you know the difference.
What order would we do that? We'd have them bear down first, and then if that didn't work, we would either do cardio version or we would do the adenosine or at the same time.
Sorry, my brain is braining.
Look at the person.
Okay, so what is adenosine used for? We know that we give it in 6
SVT.
milligrams, 12 milligrams. We know that it stops the heart rhythm, and then you get return of spontaneous normal sinus rhythm, hopefully. But what does it treat?
SVT.
SVT, not VTAC with a pulse. Okay, adenosine is for SVT. Okay. Stable, and when I say stable, it means they have a pulse. VTAC, you can give amiodarone and cardioversion. What is something that is a really nice thing to do for your patient before they get cardioverted? Give them some pain meds, because it's going to hurt.
So you do not do cardio version for SVT.
SVT. Back to the slide. So, let me. Ready to see my page? SVT, the first thing you're going to do is a vagal maneuver. And then you're going to follow up with a adenosine. What's the most important thing to remember about adenosine? Push it fast. Very, 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 very fast. Why? What is it? What about it?
The
What is the
half-life
called?
is very short.
And the half-life is very short. So if you don't push it fast, it won't.
Yes, it will not. The viability of the drug is not long enough. So if you don't push it fast to get it to where it needs to go, it's not going to work. The half-life is very short. Okay, so let's go over treatments. So we have sinus bradycardia. Our patient can be asymptomatic if they what? What's a good
Athletes.
explanation as to why? Yes.
Runners.
They're
They might
runners,
be
they're
athletes.
athletes. Yes. So a good possibility of asymptomatic bradycardia is that they are an athlete. Maybe their medication dropped them too low, like their beta blocker or calcium channel blocker or DIG. Okay. If they are symptomatic, you're going to have symptoms of decreased cardiac output. What does that look like?
Dizziness, shortness of breath.
Okay. Why? Okay. So the brain is not getting oxygenated properly. So that's why you're having these symptoms. Decreased cardiac output causes decreased perfusion to the brain, which results in hypoxia. Okay? Hypoxia is causing your symptoms. So whenever you think about decreased cardiac output, I need you to think about decreased perfusion to the noggin, to the extremities. Okay? So if you need to treat your bradycardia, you are treating with what drug? Atropine is going to increase your heart rate. If you are severely bradycardic and atropine is only really working for a short period of time, you're in the emergency room, they may do transcutaneous pacing. Okay? Maybe. All right. Sinus tachycardia. What is this? What is the rate for just sinus tachycardia? Over 100. And we have a regular rhythm. We have P waves before our QRS. Everything is regular. Our PR interval is regular. Our QRS is regular. And this can be caused from all kinds of things, right? Emotional distress. I have anxiety. I'm exercising. I'm running miles and miles. I have a fever. I'm taking too much Adderall. I'm bleeding. Okay. What is my treatment? First of all, if it has an underlying cause like anxiety, exercise, fever, bleeding, you would want to treat the underlying cause, right? If this is a situation that's occurring not really because of one of those underlying issues that you can modify quickly, but something more biological, like within the heart, within the conduction system, you might need to get some beta blockers, some drugs. Okay. If your patient is tachycardic because of their fever, what do we need to do?
Get the antipyretic.
An antipyretic. What also do we probably need to do? What is part of our sepsis protocol? When you're really, really hot, what do? Sweat.
Cool them down.
What does that?
Yes.
What you lose? What? Fluid. We
Fluid.
need fluid
Blood
resuscitation.
fluid.
Yes, fluid resuscitation. Good. Okay. We have AFib. We have A-flutter. AFib. If it's controlled, it's under what? If it's uncontrolled, it's over 100. The rate, I literally just said that. The rhythm is irregular. What are the two characteristics of AFib or A-flutter?
Irregular
No discernible
rhythm.
P wave. And what?
Irregular rhythm.
And an irregular rhythm. You must have both to be AFib or A-flutter. Your R to R is irregular. Your P wave is undefined, unmeasurable. Okay? You must have both for this atrial rhythm. Our medications are the same for both. We need to control the heart rate. The goal is to get the patient back into normal sinus rhythm. That is the ultimate goal. Okay? And once we do that, we need to keep them stable on their meds. So medication adherence is very important for patients that have a history of AFib. What is another treatment that's extremely important for patients with AFib? Anticoagulation. Let's use our big words. Anticoagulants. Okay? I do see that it says blood thinners there. It's okay. I just want you to also recognize our big words. Okay, SVT. We just talked about this. So this is a rate between what and what?
151 to 200.
Good. So you think this is a ventricular arrhythmia, right? Because it's supraventricular rhythm. This is actually a conduction problem within the atria because the P's are firing too fast. And whenever your SA node fires, guess what else fires? Everything else. So if your atria, your SA node is firing very, very, very fast at 151 to 200 beats per minute, so are your ventricles. Okay. Where are my P waves? They're hiding. Why is this not AFib?
Because
The rhythm is
Regular.
regular.
It's fast.
Yes. Yes. The rhythm is regular. See, you're getting it. She's like, no, I'm not.
I actually was just thinking, this is a stupid question. If I asked you, what if my heart rate's like 180? How would you tell whether it's normal sinus rhythm? Well, obviously it's
Or
not
SVT?
sinus because it's 60 to 100. But how would you tell whether it's just like okay or like if this is a problem?
Like, what's the difference between SVT and just sinus tachycardia?
Yeah. I mean, I'm more wondering.
No, it's not even about that. It's more about
With sinus tachy though, you would still be able to see the P wave, wouldn't you?
you would. It would just be really close. But the faster the rhythm, the harder it is to discern the P wave, which is why the P wave is kind of lost. Because it's just happening so fast.
So
that-
if I was in sinus, would it look similar to SVT on the patient? As long as it was above 151.
I don't know.
I really need to see.
I think you should look it up and tell us. Yeah. Okay. So we already discussed this like 5 minutes ago. Vagal maneuver first. If your patient is coherent and they're able to follow directions, you want to try to ask them to bear down. Sometimes your provider is going to jump right to adenosine. Okay. 6 milligrams first, then 12 milligrams after. Okay. Ventricular rhythms. This is VFib. VFib, defib.
Shock.
VFib means dead. Okay. So VFib, there is nothing happening in the atria. It's just your ventricles quivering and being like, ah, do. Here. Okay. It's completely disorganized. There is no cardiac output. And we need to start CPR. And hopefully we have an AED or a defibrillator. But the most important thing is that you start CPR immediately. Okay. This is what? VTAC. What is the first question when I talk about VTAC? Do I have a pulse? Where am I checking for a pulse?
Carotid.
Carotid or femoral. Okay. If I have a pulse, what are we doing?
Shock.
Shocky.
If I have a pulse, we could try IV amiodarone to try to slow the rhythm or the rate, or we could do a synchronized cardioversion. Say, what is the difference between cardioversion and defibrillation?
The jolts are
One is
lower.
synchronized,
and-
the other one is unsynchronized.
Yeah.
Both are correct.
And-
Both are very correct.
And
So, go ahead. And what?
The jolts
The
are lower on
joules?
the other one. The jewel,
yeah, the
yeah.
Correct.
joules on lower.
So, for cardioversion, it must be synced. Okay. And for defibrillation, there is nothing to sync to. There is no rhythm to sync to. In order to sync, you have to have a rhythm to sync to. Okay. And the joules start at 50. Defibrillation, we're at 200, baby. I need that heart to start back up. Okay. So, pulseless, CPR, and defibrillation, ACLS protocol. We have a pulse, IV amiodarone, synchronized cardioversion. Heart blocks. Our first degree block. What is the one thing, the one characteristic that tells you it is a first degree heart block?
Prolonged PR
The
interval.
prolonged QPR interval.
Prolonged PR interval. And what is a normal PR interval?
0.12 to 0.20. Sorry.
Yes. Perfect. Okay. Second degree type 1. Longer, longer, longer drop. Okay. So your first PR interval is a little long. The next PR interval is a little longer. The next one is just a little longer. And then boom, dropped QRS. Okay. Second degree type 1 Winky Bach. Our treatment. We need to assess our patient. We need to get a provider. Probably get an EKG. Any of the heart blocks, especially if they're new, I feel like I'd probably get an EKG. While we are assessing our patient, what are we assessing? Look at our symptoms. What are our symptoms coming from? Decreased cardiac output, which leads to decreased perfusion, which leads to possible hypoxia. So assessing our patient's oxygenation is very important. Okay. All right. Second degree type 2. What is my characteristic?
Some of the P's don't be for.
I drove for this thing. Anyway,
So my PR interval is what?
stay on.
Stays the same. But what have I lost? A QRS. Okay. So the difference between type 1 and type 2 is what? Okay. So a second degree block, the PR interval is constant. It can be long. It doesn't have to be normal. It can be long. It's just the same every time. Second degree type 1, the PR gets long and then longer and then longer and then boom, we drop a beat. Okay. Third degree. Whenever you think or see or go third degree, just think about me going, "Ugh, that makes me nervous."
Thought you were pushing.
No, I'm holding my sphincter because it's making me very nervous. No, it just makes me, when you get nervous, you just kind of clench everything. Yes, Jessica. Okay. So what's happening in my third degree? Who's not talking to who?
Thank you.
P is mad. She's like, you have come home late too many times this week. I gotta take care of these damn kids, and you're not here, and I'm not talking to you. P is mad at Q. She said, don't talk to me. What is my treatment?
Atropine and pacing.
Okay. Temporary pacing, which then leads to a permanent pacemaker. This is not really debatable. We must have a pacer. With the second degree Mobitz, you're probably going to have temporary pacing. And if we can't fix the conduction problem, you're getting a pacer. Okay. So these are the only two that we've talked about transcutaneous pacing, except for bradycardia, just regular sinus bradycardia. But I would say if you were going to do temporary pacing for sinus brady, your patient's going to be really symptomatic, like really symptomatic of their bradycardia. Okay. And what is this? Dead. Asystole. What does it not have? No electrical activity. Yes. What do we not do? Shock. What do we do immediately? Start CPR. Okay. I say we eat and then go over our homework rhythm strip together, the whole 13 pages. How do we feel about that? What other thing do you want to talk about today before your exam? Did you work on the list I gave you? A little bit.
I feel like
Did anybody work on the list I gave you?
We
Yes.
worked on the list, but I think I'm so stressed out that I feel like the list wasn't enough.
you lost all of cardio when I started telling. I remember nothing.
I'm like, this ain't enough key
I
points.
have-
We're missing so much information. Like, am I gonna miss something? Am I not gonna touch something? Like, I'm lost within myself. I think I'm on overload too.
Can you say what is the substitute day? Like,
Miss Simmons,
what are the characteristics?
I have a question.
Who's talking
Are
to
we
me?
gonna have Jade?
Jade. Yes.
Are you gonna actually put strips on the test?
Yes, ma'am.
But are you gonna ask us to measure? Because I'm not sure if that's gonna be able to read across on our end.
I am going to make sure that you can see the boxes.
Okay.
I'm gonna make sure that the strips that I put on there, you can actually see those little 0.04 boxes.
Okay.
Okay.
Is the majority
I
of the
haven't-
test be the EKG strips, or is it
No.
gonna be like? Oh, okay.
Are there parameters like you know how sometimes you can be like 4 numbers off or anything like that?
I think it's going to be more about interpretation.
Okay.
Like let me put it this way. If I were to ask you about a first degree block, am I going to put a strip on there that has a PR interval of 0.22? Absolutely not. That's too much room for human error and judgment,
Okay.
especially when it's it's not even a piece of paper sitting in front of you. You know what I mean?
Yeah.
So it has to be easily discernible. So
Okay. Like obviously it's a
I am
prolong.
never, yeah, I am never here to trick you. I need you to know the characteristics and to be able to say, okay, this has 0.04 squares on a PR interval. And I know that 8 times 4 is 32. And I know that 0.32 is a prolonged PR interval. And all of them are like that. And I know that that's a first degree block. That's what I need you to be able to do in your brain.
Okay.
That's what I expect from you. So interpretation and then treating that interpretation is really what I'm looking for. Do you understand what I'm saying? Okay. So do you need to know the difference between atropine and adenosine? I would say.
Yeah, there's too many A meds. I gotta get on.
It is what it is, Miss Molly. You got to learn those A meds. What other topic would you like to touch on? Cardiac is a lot. It's a lot. It's intense.
Yeah, maybe.
Talk about aneurysms a bit. The difference between TAA and a triple A.
Depending on what you have.
This is a Jessica Simmons test.
It's really hard when you're teaching and then she's reading the test because she teaches differently.
Oh, no, because I know that I'm teaching the topics on an exam. I don't care who's making the exam. If I know what it is, I'm teaching on it. But it is my exam, yes. So at this point in our studies, it's important for us to be able to be more critical thinking and clinical judgment and less black and white, right? Where there's only one answer. Because now we're getting into a territory where some of these answers, they could be really right or similar, but which one is the most correct? Because that's what your NCLEX is like. Okay? It's about being able to prioritize and use your critical thinking skills to do the right thing. Okay? I want you to think about the nursing process. ADPI, right? What is ADPI?
It's diagnosed.
Assessment, diagnosis, planning, implementation, and evaluation.
Yes. So throughout nursing school, we've been building and building and building and building. And we started with assessments, and then we learned about pathophysiology and diagnostic tools. And then we learned about planning and how to treat our patients. And then we started implementing those plans. And now we need to evaluate those plans, put it all together to make a decision using our entire nursing process. Isn't that so exciting?
Yeah.
Assessing your patient, realizing the pathophysiology of what's happening, planning your treatment, implementing that treatment, and then evaluating if that treatment has helped your patient or not. All right, come back at 12. Okay. Everyone back?
Yes. We're back.
Jessica, you said we were about to go over the EKGs.
Yeah. All right. I only have it on this computer, so I'm gonna need you guys to turn around. You hear me?
Yes.
Okay. Oh, you have it in front of you too. Okay. Okie dokie. All right. So what is the first one?
That's normal sinus rhythm.
So our rate is 90. Our rhythm is regular. We have P wave, and our interpretation is normal sinus rhythm. Okay. So our second one, what is this? Sinus
130.
Tachycardia.
Okay, so
Regular,
we have a
yes.
rate of 130 regular. We have P waves, yes.
Yes.
And our interpretation.
Sinus tachycardia.
All right. So our next one. What's our rate?
40.
40.
Are we regular or irregular?
Regular.
Regular.
We have P waves.
Yes.
Okay. What is this?
Sinus
Sinus
break.
Sinus bradycardia.
Okay. Our next one, our rate is
120.
what is our rhythm?
Regular.
Regular.
We have P waves.
Yes.
Yes.
And what is our interpretation?
Sinus tachycardia.
Good. If anybody has a different answer, I definitely want us to like go into it and, you know, and I'm sure that will happen the farther we get. But I also, if you got yours wrong, I want you to understand why. Okay. All right. So what is this rate?
60.
Good. Is it regular? Okay. Do we have
Yes.
P waves? And what is
Yes.
our interpretation?
Normal sinus rhythm.
Good. Okay. What is this one?
50.
Okay.
Regular. Yes, the P waves. Sinus bradycardia.
Good. So we understand our sinus rhythms.
Yeah.
You guys are okay with your sinus rhythms? Yes?
Yes.
Yes.
All right, so let's go into our atrial arrhythmias. So what is our rate here?
90.
90.
9.
Are we regular or irregular?
Irregular.
Irregular.
And do we have P waves?
No.
No.
Okay.
Oh.
Okay, so what is this?
AFib.
AFib.
Is it controlled or uncontrolled?
It's controlled.
Control.
Control.
What makes it controlled?
Under
heart
100.
rate.
Less than
Under
100.
100.
Under 100.
Good. Very good. What are our two characteristics of AFib?
Irregular rhythm
Rhythm and no P wave.
Okay. What is our rate here?
170.
70.
Good. Are we regular? So we automatically, it's not what? AFib.
It's not
AFib.
AFib.
Do we have a P wave?
No.
Undetectable.
So can we measure our PR interval?
No.
No.
What is this?
SVT.
SVT.
What is our treatment for SVT?
Vagal maneuvers.
Vagus maneuvers, if not adenosine.
No, it's adenosine. Adenosine. So vagal maneuver first. So start with your least invasive, right? Telling someone to bear down is pretty not invasive. Okay. Adenosine and making someone's heart stop sounds pretty invasive.
Very invasive.
Okay. What milligram do we start at?
6.
If 6 doesn't work, what do we go to?
12.
Good. Okay. What is my rate?
90.
90.
Regular or irregular?
Irregular.
P waves.
No.
No.
PR interval.
Not
No.
measurable.
Unmeasurable. What is our interpretation?
AFib.
Controlled AFib.
Controlled AFib. Okay. What is our rate?
80.
80.
Is it irregular or regular?
Irregular.
Irregular.
Do we have discernible P waves? What do we
No.
have?
Sawtooth.
Sawtooth. What is our PR interval?
Unmeasurable.
Unmeasurable.
Unmeasurable. Yes. So what is our interpretation?
A flutter.
Atrial flutter.
Controlled. Okay. Rhythm, or I'm sorry, rate.
190.
I got 200.
Yeah, I got 200.
How? I count 19.
Yeah, I got 19. I got 190.
One,
Yeah, I have
2,
190.
3, 4, 5, 6, 7,
Because the
8,
first one is cut off.
11, 12, 13, 14, 15, 16, 17, 18, 19, including the last one that's half.
Yeah,
Oh,
I
The
can't see
first
the
one is
first
cut
one.
off.
So the first one
I
looks
don't
just
have
like
the
the
first
last
one.
one, so that's why we counted the first one and it added up to 200.
So on my paper, I do see that up there, it does look like it has like half of a QRS. On my paper, I don't see it at all.
Yeah, my paper either.
Okay.
My
Oh, I
paper
see
put
it
it
on the
just like the
screen.
slide.
I see it. I see it on the screen. So yeah, this is a poo. I wouldn't use this. If I was going to use this strip, I would cut off one of those little guys because I would have said 19. On my paper, it's definitely 19. So you're definitely not wrong saying 200 because I mean that's definitely a half of a QRS right there. So yeah, if this was on an exam that I didn't make, I would accept 190 or 200 for sure. Okay, are we regular?
Yes.
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 Do we have P waves? Okay,
No.
No.
Visible.
so our PR interval is
Unmeasurable.
No. Unmeasurable.
This is what?
SVT.
And we
SVT.
treat it with which A drug? Adenosine.
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 Yes, baby. I love that you guys participate online. It makes me so happy. Okay, what is my rate?
70.
70.
Good. Are we regular or irregular?
Irregular.
Irregular.
Good. Do I have a P wave? What do I
No.
have?
Yes.
Sawtooth.
Sawtooth. And can I measure a PR interval?
Unmeasurable.
Unmeasurable. Controlled A flutter.
This and the part block.
Well, this is dead.
You're clearly dead.
So when I turned in my homework, I forgot to erase and I wrote AFib crazy as hell. So I'm sorry.
AFib crazy as hell. Okay, so do we have a rate? No.
I put question mark, so I'm gonna put no.
Crazy.
Do we have a rhythm? No.
No.
Do we have a P wave? No.
No.
We cannot measure nothing. There ain't nothing to measure. This is VFib.
VFib.
Which
Yeah.
VFib we? DFib.
Stop.
VFib is dead. Okay. What is my rate?
170.
I got 180.
The top to the bottom because I put on this one when we were doing it too.
The top to the bottom. Okay, so I want you to think about, so when we're talking about, by the way, what is this? This is VTAC,
VTAC.
okay? So when we're talking about VTAC, those big, huge, wide humps are very wide QRSs, okay? So when you are looking at the tops of them, what is the top of it? It's your R wave, right? So I would have counted this as 180. Because I have so that first, I understand that first hump, that is your R. Because when it goes back down, that is your S. That's the end of your QRS right there. Okay. So you're looking at an extremely wide QRS complex. Okay. Is it regular? Yes.
Yes.
Do I have a P wave? No.
Not visible.
So there is a difference between a wide QRS complex VTAC, and there can be a more narrowed version. It looks very similar. It's still very spiky. Like it's, instead of it being like a hump, it's more of a spike with just continuous spikes. And that's what we called a narrow complex VTAC. So on this paper, and I do not expect you to list the difference, but this is one that we call monomorphic. It is wide, it is the same. There is one characteristic here. So mono meaning one. So this widened QRS VTAC pattern, it can be referred to as monomorphic. I do not expect you to know that on your exam. Okay. I just want you to be able to recognize VTAC, whichever way it presents. Okay. Okay. What is this?
Assistally.
What do we do?
CPR.
CPR.
What do we not do?
Defibrillate.
Electrical shock.
Defib.
That's okay. I like this. Okay. So what is my rate here?
140.
140.
Is it regular? Do I have P
Yes.
waves?
No.
What is this? This is VTAC.
VTAC.
Retech.
So remember
So I'm gonna guess this is narrow.
So remember what I just said, right? VTAC can look different. Okay, it can be lumpy, it can be spiky. What are the characteristics of VTAC? We have a rate between 100 and 250. Okay, we have a wide QRS. Okay, and we have no P waves, no discernible P waves. So there's no measurable PR interval. So this is more, so the bottom of it is real wide, but the tops of them are narrow. So this could be a more narrow complex VTAC. Okay. But the important part is that you understand and know that both of these are VTAC because they both have the same characteristics, even though they look a little bit different. Does that make sense?
Mm-hmm.
Is our patient alive or dead?
Dead. Oh, the next one? Dead.
Yeah, dead. DED, dead. What do we do?
Shock.
But what do we do first? CPR.
Start
Yes.
CPR.
Always start CPR first. You're always going to start CPR first. But it's important to know that this is a shockable rhythm. Okay. So if, say you had a question that said your patient is sitting in front of you in VFib and your answers are defibrillate or start CPR, first of all, I don't know if this patient has pads on them. If it's asking me the priority and it's not telling me that this patient has a defibrillator or an AED on their body, I am starting CPR. Okay? That's when we need to think about prioritizing our nursing interventions. Okay? Okay, so this is the one that I was referring to on your homework. This is not asystole. And it absolutely says on here that it is asystole.
This would this be considered? This was the fine defib, right?
Yeah.
And when I was looking over this, and in order to prove it to myself, I looked up many examples of fine VFib because I wanted to make sure I was giving you guys the right information. This is not asystole. These little jumps and waves in this, that is a form of electrical activity. Okay. Now, if you had a line that had a wave that was going like this, do you guys see my hand? Can you see my hand? Where it's like a wave in the ocean. That could be considered asystole. I mean, it's basically flat. There are no jumps, spikes, nothing like this, right? It's a very small, little tiny wave within that one line. That is still considered asystole. This junk is absolutely fine ventricular fibrillation. Okay. Okay. We did not talk about PACs yet. Or PVCs. So we're going to go over that right now. So a PAC is a premature arterial contraction. When you have a PAC, it occurs when you have a random firing, an early firing of the SA node. So everything about this rhythm is normal, except for that fourth beat. Okay. The PR interval is normal. The R to R interval on all of the other beats except that fourth beat is normal and regular. That fourth beat we refer to as a PAC, premature atrial contraction. Okay. So it's not a skipped beat. It's not a block. It's not anything like that. It is a P wave that has fired too early in the rhythm, in the cardiac conduction. And it is the only outlier on the strip. Okay. So when you have PACs, it's not something that happens consistently where it's happening one after the other, after the other, after the other. It's happening randomly in your cardiac conduction. Okay. So the interpretation of this is normal sinus rhythm with PAC. And a lot of times we number which beat the PAC occurs on. So this one is a normal sinus rhythm with PAC fourth. If this were to have happened on the sixth beat, it would be sixth. If it happened on the second beat, it would be second. Okay? So the characteristics of a PAC is that everything about this rhythm is normal except for that one early beat. And it's happening because the SA node fired a little too early. So that whole complex, if you can see on my paper, is circled. See that whole thing circled? My little circle up here? Is it too far away? I have a circle around the whole beat. Can you see is my camera on?
Yeah.
Okay. Do you see my little circle? So that whole beat
Yes.
is considered a PAC. Okay. So when we talk about PVCs, a PVC is a premature ventricular contraction. Okay. They happen randomly. You or I could be having a PVC right now. Okay. They could be caused by caffeine, anxiety, just regular old sitting there. PVCs aren't a problem until you have a lot of them occur in a row, which could then be a run of VTAC. Okay. But a PVC by itself is most of the time asymptomatic. Hold on. What was I was looking for something. Okay. So when a PVC occurs, you see how there is a pause after that PVC, after that contraction. I want to point, but it's too far away. The third beat, how wide that is and how long it is, that is your PVC. So you have QRS, QRS, PVC, QRS, QRS, PVC. Okay, you see that? So you see how long that space is between the PVC and the next beat? That is called a compensatory pause. That is a characteristic of a PVC. Okay, so whenever PVCs occur, it is normal to have a compensatory pause afterwards before you have another QRS, another regular heartbeat. So your QRS, or I'm sorry, your PVC usually has, it can be a narrow or wide QRS complex. And then you can have a big dip or spike in the T wave. And what's specifically about this rhythm right here, this strip right here, is that it's inverted. It's upside down. And it's inverted because why? What did I tell you about?
It's on a different lead. It's supposed.
Yes, it's on a different lead. So if you look at the next rhythm, this is what PVCs normally look like on a lead 2 strip. So you usually have this big spike that goes down, and then you have a wide T wave with that compensatory pause. And then it goes right back into, usually, right back into a normal sinus rhythm. Now, the kicker here is that we don't count PVCs as a beat. Okay. So my rate for this is 50 with 3 PVCs. Jade, you look confused. You're like, I don't know what you're talking about, girl.
Yeah.
Okay.
What the information, the last one we did.
The last interpretation was sinus bradycardia with PVCs because the rate of that last one is 40.
We did this.
Please don't let Maria teach you EKG strips. Let me do it.
So
Yeah, because I'm so confused because the one that you just said was 50 with 3 PVCs. I had that, and she said we're supposed to count the PVCs, and she said it was 80.
with 3 PVCs. So
So that
I'm
confused me
sorry.
now.
Our the day we had for VSIM told us to shock asystole.
Who?
Shut up. She sure did.
You better tell me who it was right now.
Poochie.
Her name is Poochie. Poochie.
That was when we
Save
knew
us.
to block her out. We listened to you. That was when we knew to block her out and don't listen to nothing else for the rest of the day.
Thank God.
so we're just
Counting so
just to be clear, we're
counting the QRS as the ribbon. We are not counting the PVCs as a rate.
Correct. I'm going to
okay.
plug my little camera guy in so you can see my paper.
So for the one for the middle one, it was 40 beats with 2 PVCs.
40
it was 3.
the middle one.
I see 3. No,
The
the
middle
middle
one.
one.
I'm gonna hold on. I'm putting in my camera.
Okay.
Let me get my camera so I can show you. It's okay that you got them wrong. That's why we're doing it together. Oh yeah, you're on the thing. Okay. How do I make this more clear? Ah! Ooh, look at that. That was nice. I just pressed a random button too. Okay. So if we're looking at our first one, remember I was saying this is my early beat, right? So this is my PAC, and it's occurring on my 4th beat. Okay. These are my PVCs. This entire complex is a PVC. Now remember, I said it's inverted. So do you think that this is a functioning, good cardiac output beat. This is an arrhythmia. Okay. So this is not counted towards your heartbeat. Right? So we have a rate of 1, 2, 3, 4, because these are my normal QRSs, right? Here's my P wave, here's my P wave, here's my little P wave, here's my little P wave, okay? To my QRS complex. And then this is my PVC, okay? So the next one, here's my regular P wave, my normal QRS, my regular P, my normal QRS, right? This is a wide QRS complex with a peaked T and a compensatory pause, okay? So this right here is your arrhythmia. Everything else is normal. These are normal. This is normal. I have a 0.20 PR interval. My QRS is normal. So what are we having a hard time about with this one?
I guess I was just confused because I originally had how you have it with the 50, but she was saying that the PVCs are count as a beat. So that we're supposed to add those as a beat, which would have made the rate 80 instead of 50. So that's where my confusion was coming in, if the PVCs or the PACs are actually counted as a heartbeat, as a beat.
Mm-hmm. So PACs are counted as a heartbeat because the only thing that makes the PAC different is that the SA node is just firing a little bit early. It is a normal P, it's a normal QRS. This is a normal contraction, atrial and ventricular contraction. Okay? It's just coming a little bit early.
Okay, I get that.
A PVC is an abnormal arrhythmia. This is an abnormal beat. And PVCs, this is not a P wave, this right here. What is that? That's a T wave. That T wave belongs to this QRS. That PVC has no P wave. It is not a normal cardiac conduction. There is no atrial contraction. This is a premature ventricular contraction. So if you look at these also down here, there's no P wave. This is a T. This beat belongs to this QRS. This T belongs with this QRS. These PVCs have no P wave.
Okay, that makes sense now.
That makes
I
more sense
understand.
why we're not counting it. The only time I'm counting PVCs is when they're consecutive. If I have 2 PVCs, 3 PVCs, 4, 5, that's when I call my provider and I say, hey, my patient just had a run of PVCs, 5 PVCs in a row. Okay. PVCs become a problem when they are what's the word? Consistent and one after the other. Okay. How do we feel about our PACs and our PVCs? Okay. PACs are kind of annoying. I always felt like I got confused about what an actual PAC was because everything else was just normal. And then it was like, is this even an issue? It's not really an issue. Most patients are asymptomatic when it comes to PACs, and it's not a big deal. It never really causes an issue. PVCs, I always just recognize them as a just big random spike. That's what it always looks like. It just looks like a random spike that just doesn't belong. It doesn't look like the other QRSs because it's just a big spike that just occurs out of nowhere. Okay. Most of the time, your PVCs, a patient with PVCs is asymptomatic. I swear I have them all the time. Sometimes I feel like my heart kind of like skips a beat sometimes, and I bet you it's a PVC. Because some people can feel that way in their chest. They could just kind of feel like this weird sensation in their chest. Like, I don't even know how to explain how it feels to like drop a heartbeat. I don't know. It feels funny.
kind of like a dip, like your heart goes like that.
Yes.
Yeah,
Yes,
I get them
it's
too.
actually like a physical sensation of like a.
Yeah, I get them when I
You're
drink
on a roller
Celsius.
coaster.
Yeah,
That's
when I
don't drink.
drink, I get them when I drink Celsius.
Yep. Yep. That's why I only drink coffee with like my caffeine as like coffee because I think it's all the extra stuff they put in the energy drinks that's what causes me to have like weird chest sensations. Like the I don't even know what they put in those things, but they put all those extra ginseng and niacin and blah blah blah. I don't even know what it is, but I don't like it. Makes me feel funny. Okay. So, moving on to our next one. So, I mean, this already has all the answers on it, but these are new. PACs and PVCs are new to us, so it's okay that we're looking at the answers, right? We're working these out together. So we have 1, 2, 3, 4, 5 beats. We have a rate of 50. It's irregular because our R's are not the same all the way through. We have normal P waves. We have a consistent PR interval of 0.20. Okay. So this is sinus bradycardia with a PAC on the 4th beat because 1, 2, 3, 4th beat. Okay. How do we feel about the characteristics of a PAC? Feel like we're pretty clear on that? Okay. How do we feel about the PVCs? Do we feel okay about the PVCs? I don't hear anybody talking to me. I see Jade give me a thumbs up, but nobody else is saying anything.
Yeah, I feel a little bit better about it after you explained it.
Okay, Brianna,
I
you're
got
good.
it.
Erica gave me a thumbs up. Jade is good. Keeks, you go okay?
Yeah, I think I got it over here. It's Rashonda.
That's good. Okay. All right. So, where's my answer? We're going to move on to heart blocks. Okay. So we have 1, 2, 3, 4, 5. Right? So what is our rate?
50.
Okay. Are we regular?
Irregular.
They're irregular. Okay. So one thing, especially I liked to do back when we actually had paper, is that I would mark where my P starts and where my R starts. And usually, and it would be thinner with a pencil because this is a bold pen. But it was easier for me to kind of count between if I marked it out first. So I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Is that right? Yeah, I'm gonna call that 10. So what is my PR interval right here?
Prolonged.
Okay,
Gradually prolonged.
what's the number?
40.
40.
Okay, so then I have PR right here. So we have 1, 2, 3, 4, 5, 6, 7, 8. What's 8 times 4?
32.
Okay. We have 1, 2, 3, 4, 5. I'm gonna call that 5.5 because that guy's all the way over there. So what is my PR interval on this first one? I'm gonna call it 22, 0.22.
22.
I swear, I feel it's like a 5.5. Okay. And then here's the beginning of my P. I got no QRS. I just got another P.
Mm-hmm.
So what is this?
Second degree type 1.
Also known as Wikibach. Okay. So this is a second degree heart block type 1 Wikibach. I know, it's one of my favorite words. You know. Okay. So let's look at this next one. So I have start of a P here. There's my QRS. I have 1, 2, 3, 4, 5, 6, 7, 8, 9. What's 9 times 4?
36.
Okay. So now I have a start of a P here. And then my QRS is here. 1, 2, 3, 4, 5, 6, 7, 8, 9. One, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay. So, what's happening with my PR intervals?
Prolonged.
They're the same and they're
They're
long.
the same.
So what kind of block is this?
First degree.
Yes. This is a first degree block. I disagree that that's 0.4 seconds. Okay, so we all can see that this is a first degree heart block. We all agree? Okay. What's my rate?
50.
Okay. Am I regular or irregular?
Irregular.
What is my PR interval?
Point 6. 0.6. Oh no,
P
you're counting more. Oh, I see.
Are my PR intervals
24.
Are they? Are my PR intervals different? What are, first of all, what is my PR interval on the first one?
I say 24.24.
Okay. I counted 5 little boxes, but I have a thick pen and it's hard for me to see this little stupid paper. So I would have accepted 0.2 or 0.24. Okay. And then over here, 1, 2, 3, 4, 5. I feel like there's only 5 boxes there. So I feel like that's like a 0.220. And 1, 2, 3, 4, 5. I feel like that's also 5.
Mm-hmm.
So if my PR intervals are constant, but what else has happened? I dropped a QRS twice, 2
Yeah.
times. So what is this? Also
Second
known as
degree. Morbits.
Mobitz. Second degree heart block, type 2, Mobitz 2. What distinguishes type 1 from type 2? Clematis. I see you, girl. What is the difference between a second degree type 1 and a second degree type 2? You need somebody to come save you? Or is your mic not working? Mayana.
Is it the 3?
Go ahead.
Well, I just remember in my head is longer drop. So in my head, that's the difference. The 3 regular rhythms and then the drop in between. The drop after, right? And that would be the wiggy bop. That would be the first degree, right?
That would be type 1. Go ahead,
Type
Mayana.
1. Yeah, that's what I mean.
Mayana, go ahead.
The type 2, the PR stays the same.
Yes. And the type 1, the
The
PR.
PR gets longer and longer and longer. They
And then
both are missing QRS.
Right. They both have dropped QRS. Good. Do we all feel confident on the difference between a type 1 and type 2 second degree block?
I have confidence that I know what the difference is, but not that I can measure the exact box. Can I have a calipers anyway? If I want to have a magnifying glass in the test, then yes.
Listen, I have no idea if ATI comes with a magnifying glass. I'll make it as big as I can.
Thank you.
Bailey, how are we feeling about the 2? Abby, is it okay if I call you Abby? It says Abigail. You go by Abby?
Yes, I do not go by Abigail.
Abigail. All right, Abby, you're
fine.
The 2 Baileys, Bailey 1 and Bailey 2, Bailey D and Bailey
Iffy.
Iffy.
Mm-hmm.
On everything or just the type 2s or second
Just
degree?
the type 2s and type 3.
So type 1 versus type 2, we're a little iffy on.
Yeah.
Okay. Rashonda, how we feeling?
I feel like the more I do them, the easier it'll get. But I got the basics down.
Okay. Practice, honestly, when it comes to rhythm strips, practice is going to be really important. Erica, how are you feeling?
I feel okay.
Okay.
Just I have to keep doing it more.
Yeah. Practice makes perfect. Kiara? Are you at work?
Yes. But no, I need to practice more too.
Okay. But is it making sense?
Yeah, it makes sense, but I'm still confused on the blocks.
Okay.
Banana, strawberry?
Are you on 7 South right now?
Mhm.
No, I didn't. I don't need a lunch though.
Did you hear
You
me?
there? Yeah. Is there
Yeah,
anybody
I'm
there I
here.
know?
Oh, yeah.
Carrie.
Me and Miss Kiki worked together about 12 years ago.
Who are you talking
10 years ago on 7
Do you
West.
remember Jess? Were you here when Jess was here?
about? Give me some background.
Is Banan still your manager?
Yep, she's here.
Wild. Wild.
We're calling new people.
All
Everyone's
right.
left since she's gone.
I know, isn't that sad? Okay, we're moving on. Oh, we skipped that one. We skipped our complete heart block. So this middle one on this page, we got a P, 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 P, and then we got a QRS. We got a lot of P's and not a lot of Q's. Yeah. What did you put?
Yeah, I had third degree at first. My instructor said it was second degree.
Who's your instructor?
Shauna.
Well, Shauna, she gonna have to go back to the. Now, hold on a second here.
They said it was second. She said second degree type 1.
It can't be a type 1 because there is no longer drop, right? A characteristic of Winky Bach is that it's longer drop on the 4th beat, right?
Right.
So, yes, is the PR interval really long? Yeah, but it's because the P's and Q's are not talking to each other.
Right.
Right?
But when you say
They are independent from each other. Yes, it is random. So look at here. This says QRS complex is 0.08 seconds and independent from the P wave. So here's another thing too. How many? 1, 2, 3, 4, 5, 6, 7, 8. I have 8 P waves. I have 1, 2, 3, 4 QRS complexes. If my P's and Q's were talking to each other, they'd be the same. If this was a second degree Mobitz, my PR interval would be consistent and I would have dropped QRSs. So what makes this not a Mobitz type 2? What did you just tell me about the PR interval? They're not the same. They're not constant. So what is a characteristic of Mobitz type 2? The PR interval is constant. This is not constant. So that's the thing when it comes to a third degree. The slower the rate, the easier it is to recognize. So say this rate was like 25. like on the monitor, you saw the rate was 25, 27, 30. It's a lot easier to recognize when there's only 3 QRSs. When you throw in more than 3, it's harder to recognize because you're trying to associate the P's with the Q's. Because it gets more junky, right?
Missing QRSs.
Mm-hmm.
We've got P to P, and then a QRST, and then P to P, and then a QRST, and then P to P.
But what are your QR intervals telling you? Or I'm sorry, your PR intervals telling you?
That it's not a type 2.
That it's not a type 2. And it can't be a type 1 because we don't have longer drop, right?
Okay, I see it. I see it. Do you see what I'm talking about, though? I mean, yeah, but you're dropping it.
So here, Molly, here's the thing. Here's what you're doing right now. You're trying to rationalize an answer that's not true.
I know. I understood more so. Like, if this is something I saw in the real world, I would see it as that. So I want to make sure I can figure out a way to not see it as that.
Okay. So you're not seeing it as that because type 1, you would have 3 QRS complexes in a row. You would have 3 beats in a row, full beats, P, QRS, P, QRS, P, QRS. But the P to R is getting longer, and then boom, we have a P without a QRS. Okay? This is a QRS and 2 random Ps. A QRS, 2 random Ps. QRS, 2 random. This could be anything. This could be a QRS and 3 random Ps. You gotta look at the whole complex. What's happening everywhere? Because like I said, the higher the rate in a 3rd degree heart block, the harder it is to distinguish what it is because there's just too much happening. How do we feel about this complete heart block?
Sure.
Did you say stressed? Yeah, I get
Yes.
stressed when I see 3rd degrees too. All right, we're almost done. We're going to power through, okay? Because it's already 1:06. All right, so the last one, I don't know if you already saw my answer. So here's the start of a P. Here's the Q or the R. 1, 2, 3, 4, 5, 6. I'm going to call that 6.5. One, 2, 3, 4, 5, 6, 7. One, 2, 3, 4, 5, 6, 7. Two, 3, 4, 5, 6, 7. So how many beats do you think you need to establish if you have a heart block or not? And you're interpreting a rhythm strip. How many heartbeats do you need to measure and count for you to realistically be able to interpret what type of block this is?
I would say at least 3 to 4.
3. At least 3. At least 3. So I've just measured my PR interval with 4 heartbeats. And
First
they
degree.
are almost all completely the same, which is a characteristic of a first degree heart block. Annalisa, is that a good face or a bad face?
No, that's a good face. I said, oh, I got it right.
Oh, good. It looked celebratory, but I just wanted to make sure. I love this little camera thing. When I need it, it's like the best thing in the world. When I don't need it, I really don't care about it. But having it is really cool. All right. I gotta take my glasses off. Do you have the paper? Way wrong?
Literally can't see anything on these papers.
I'm looking at the same piece of paper as you.
We all get the wrong answer or all different answers. I can't see. I would have said 5 here, and I can see that you're not counting the same as that. 2. I would have said 4.
And I'm saying 4.
Yes.
Okay. So what's happening here? I know you guys are probably blinded by my big fat diamond.
Yeah.
Blinded by the diamond. All right. So
Oh,
I have.
Is that a Mobits?
Yep,
It sure is, Miss Annalisa.
sure is.
Who, me? Why? What am I serious about? Yes, I'm serious. Yeah, the PR interval is constant.
Or your 2 are outside.
0.08. There's only 2 boxes between that QRS.
Oh, I was right.
This is a second degree heart block, type 2, Mobitz 2. The
Type
PR
2.
interval is constant.
Understood. Got myself there. It doesn't matter where the drop is on the.
No, it only matters where the drop is on the type 1, on the Winky Bach.
So the drop can be anywhere as long as the PR.
Were you, why? What were you thinking?
I don't want to tell you.
Heart block.
Yeah, complete.
Okay.
Because if there's P2RS, it's just P2RS,
Okay.
and I was thinking there's not 3, but it doesn't matter.
What is the rate on a complete heart block? Less than 60.
Okay, well then that's already ruled out.
9 times out of 10, your complete heart blocks will be less than 60 beats.
Right.
No, I would never do that to you.
Yes.
Okay. What is the rate for my next one? 50?
50.
Okay. I want you to tell me how many P waves you see.
I feel like I only
5?
see 2.
See 8.
I see 5
I see 1,
or 6. I didn't count that one.
2, 3,
It's 4 of them.
4,
Oh, okay.
5,
No, it's 5.
6,
Oh, I didn't
7,
count that one.
Mm-mm.
8.
Oh,
Oh,
geez.
it's 8.
I see 1, 2, 3, 4,
Oh, this is 3rd degree.
5.
So this is
QRS.
yes.
Yes. This is a complete heart.
Complete.
There is no relation between my P's and Q's. And the rate is under 60. How do we feel about that one? I feel like we got there quicker this time. That's okay. Okay. Okay, now I told you that I did not want you really getting into junctional rhythms. Okay. Um, the yeah, I don't want to do this. I really, I mean, if it's okay with you guys, I really do not want to get into junctional rhythms because I don't want to confuse you. We have enough that we are covering. I am not going to test you on it. And yeah, are we all okay with that?
Agreed.
Yes.
Work for me.
Miss Simmons.
Yeah.
So I turned this in yesterday,
Mhm.
but like where you told us to stop,
Mhm.
I'm gonna return it in with the rest of it. So
That's fine.
just disregard the first one.
Totally fine.
Yeah, I was gonna say I turned mine in too, but I stopped where you told us to stop. So do you want us to finish it and resubmit?
Yes, ma'am.
Okay.
Oh. Okay. Do we feel better? Come on. Not even just a
No,
little
I'm
bit.
stressed. Mm-mm.
In
I
percentage.
need a cigarette. I don't even
I
smoke.
think I just have to practice the heart blocks a little more because I was practicing the other ones, so I feel like I know those a little more, but I feel like I just need to go over the heart blocks a little bit more, so it's kind of a little easier now that we went over them.
Yeah, me too. The hard blocks are a little confusing still for me.
You know what would be an interesting question? Say you had a question that had a heart rhythm that was 3 QRSs and 8 P waves with a rate of 30.
3rd degree.
And we recognize that it was a 3rd degree heart block. That's part 1. And then part 2 says, what is your treatment? And your options are CPR, defibrillation, atropine, or transcutaneous pacing? What is your answer?
Pacing?
Transcutaneous pacing is your answer.
Oh, I got it right. Thank
So would it be a surprise to see a question like this,
you. No.
where the first point is interpreting your rhythm, and the second point is treating your rhythm? I also want you to remember that this is a 50-point exam, and I am not going to have 25 points on EKG interpretation and treatments.
How much?
She said, I wish you would. I mean, I would say 3 to 5.
Oh, no. Thank you.
But if there's 5 and they're all worth 2 points each, and you miss all 5, that's a 10-point deduction right off rip.
It's just like I want to know whether I should focus more on beating the other stuff into my brain or this. And now I know that it's other stuff.
I've given you a list.
Anything to add to that? I really thought those arrhythmias were going to take precedent. Are we happy with?
I'm happy with the list. I forget, Erica and Mayana, when we were talking about the TAA and the AAA, I feel like I said something.
It was just what I have written down is like the AAA pulsating abdominal mass do not palpate. And then if it's a rupture, that one's severe back pain, abdominal pain. The TAA is rupture, you'll have a severe chest pain and back pain. That's the only thing that
Like a
And the pop. Like a sudden pop.
Could be, yeah. Sharp stabbing pain. I'm freezing right now. In the chest for thoracic, in the back chest for a AAA. What you would expect to monitor for post-op. AAA. How would you know if something was failing or wrong? What would that presentation look like?
So are those gonna be selecto that applies, like the treatments and?
What do you want me to tell you? You want me to give you the test? You want me to give you the questions? Like, if you want.
This is a long week. I think we could use a little extra help.
I could use all the help I could get. Absolutely do not let Maria teach you EKG strips anymore, because now I don't trust her with that interpretation. Please don't tell her I said that. But I don't want you getting confused by someone else teaching you the wrong thing. If you have questions, you know how to get a hold of me. You know that I am available. So please use correct resources. If by chance I am not available, I want you to write it. I don't care if you write it down. I don't care what you do. But if I am not available and you need help with EKG interpretation, you are going to email Angela Cottrill. Okay? Do you know who that is? She's on the
Yes.
Well, I know you guys. But she's on the math committee. Her email is ACOTTRILL at rosseducation.edu. Because who knows what it's going to be like with ABHES tomorrow. And I don't want to leave you hanging. So if you need help, do I want you to practice with your peers? Yes. But I also need you to remember that your peers are also students. They are not experts. If you don't know the answer and they don't know the answer, or they think they know the answer, and then they're teaching you something opposite of what you have just learned from me, please reach out to a person that is actually going to teach you and give you the correct answer, AKA Ange Cottrell. Okay? I hate when you guys get into, like, fall into a trap where you're like, well, I was studying with so-and-so and that's what they told me. Okay? Yes, we can rely on our peers, and I love that you guys study together and I want you to, but sometimes your peers are wrong, and that's okay. I just want you to reach out for help if you need it. Okay? And I will absolutely do my best to be the one that helps you. Is that crystal? Okay.
Yes.
You said it's very similar to what we did last month.
The math test is literally the same exact test that you took last month with different numbers.
I did have a question because on the grading part of the platform, the ATI math thing is on there. But you said we didn't have to do it, right?
Oh, yes, I forgot to ask about that. Erica and Mayana, you were supposed to remind me. I completely forgot.
I sent you an email. You must not have seen.
Listen, I've gotten so many emails. Okay. It is not on your syllabus. It is not on your course overview / calendar. I am not going to require you to redo that math module unless you fail the first math test. Then I will make you do the math module. Deal?
Deal.
Okay. Now, we all saw on Brightspace that there is a math worksheet. Did you not see that? You didn't look?
Yeah, I seen that. I did do that.
That's just for practice though, right?
Yes.
Okay.
I only had 2 people attempt it. Hey, and both of you passed.
Oh, that's me and you, Luna.
Good job. You both passed.
I did the worksheet too, but I missed 2.
I only had out of 10. 1 all the
I was
way
gonna
up.
say, I know a bunch of us were doing it. I know
You must have not like actually submitted it.
I did, and then I got a reminder I got a alert from Brightspace saying it was the grade was updated.
Oh, you guys are separated. Remember, you're separated in those 2
Oh,
groups.
that's right.
So I'm probably just not looking at it's a whole separate course for you guys for the NUR 2852. Yeah, it's an actual quiz.
My brain apparently died on break week.
Let me look at it. Let's see what it looks like. Yeah, there's you want to do one together? Yes or no? Abby said no. Why are you saying no, Abby?
Yeah, we can do it together.
Because I have to
Hold
go
on.
pick up children.
It's actually 1:30, so I'm gonna log out
Okay,
because I have to go get my kids.
you're fine. You can go
Thank
at
you.
1:30. This is recording. I will send it to you guys. If anybody wants to practice this with me, you can stay.
Thank you.
Thank you. Have a good day.
You're welcome.
Thank you.
Bye.
Bye.
Okay, so the patient is prescribed an oral elixir with a dosage of 2.5. Bye. Milligrams per kilogram per day. Oh, let me turn my little thingy back on. Can you guys see the problem? Because I was gonna turn this little camera thingy back on. Well, I would change it to this for you guys to see how I do the dimensional analysis.
Oh, I don't do that. I'll have to cover my eyes.
Oh God.
Any of us. I can't. Not even one of us.
Please don't tell me that.
Okay. Cover your ears and I'll cover my eyes.
Okay, so the patient, wow, I can't even spell. Patient weighs 48 kilograms. So available, I have 1.25 milligrams per ml. How many mLs of the drug should the patient be given in a single dose if it needs to be taken 2 times daily? So first of all, I need to figure out my max dose. So 48 times 2.5 is what? $120? And that would be milligrams per day. Okay. So the label on the bottle reads 1.25 milligrams per milliliter. How many milliliters of the drug should the patient be given in a single dose if it needs to be taken? My brain doesn't want to brain. So I'm looking for milliliters. Oh, wait a second, what happened? What happened? Why is this giving me different questions? Oh, because it probably shuffled the questions. That's so dumb. Okay, so what answer did you get? What did you guys get? Erica? Are you doing it?
No, I didn't do it. I'm just trying to see if I do it right, but I didn't do it yet.
Oh, okay.
But don't wait for me.
Okay. The answer is 48, yes. Mm-hmm. Do you want to do any of the other ones? That was just the first one that popped up.
I'm just gonna do that. Yeah.
The what? Oh, okay.
And it'll grade it right there.
You have to submit the whole thing for it to be graded, yeah.
I mean, I usually feel fine about math. I just honest to God forgot what we even did last month for math.
That's okay. That's why there's a worksheet there.
That's my biggest problem is I go right in between classes. Obviously, I never do anything to study for the math first because I'm more worried about the exam. Yeah, well, I feel like.
Okay, well, I really don't want anybody to fail because of math again, okay?
The not being Kelly being made. I would feel Kelly about the test. I know because they always basically done is a bunch of Kelly and now it's only 5 questions. You know, I know about pulmonary.